Hello everybody, my name is Laura Sargentini and on behalf of Sanofi I would like to share a recent experience on the use of modeling and simulation to provide guidance for pediatric doses for the treatment of a rare disease. The title of the presentation is Caplacizumab Model-Based Dosing Recommendations in Pediatric Patients with Acquired Thrombotic Thrombocytopenic Purpura. Acquired thrombotic thrombocytopenic purpura, also known as ATTP, is an acute immune-mediated hematologic disorder where patients produce autoantibodies that inhibit the von Willebrand factor cleaving enzyme ADAMTS13. As a result, ultra-large von Willebrand factor hyperadhesive multimers become present in circulation, leading to spontaneous platelet aggregation. ATTP is a rare disease with an incidence of 1.6 to 6 million per year in adults. In children, the incidence is even lower, about 3% than in adults, but with similar clinical features. The treatment of ATTP relies on three pillars. The first intervention is the use of plasma exchange, providing functional ADAMTS13. The second pillar is the immunomodulation, to reduce the production of autoantibodies, the cause of the disease. But as the immunomodulation takes time to become effective, the use of Caplacizumab as an inhibitor of the platelets adhesion protects the patients. Caplacizumab, in fact, is an anti-von Willebrand factor nanobody inhibiting the formation of platelet strings and consequent formation of microthrombi. This slide illustrates the absorption and disposition properties of Caplacizumab. After a rapid and almost complete subcutaneous absorption, the free nanobody forms complexes with the circulating von Willebrand factor. The free Caplacizumab can undergo renal clearance, whereas the complex Caplacizumab distributes to well-perfused organs where it is catabolized. Overall, the pharmacokinetic profile of Caplacizumab is characterized by target-mediated disposition. As already mentioned, ATTP is a rare disease, even more in the pediatric population. The clinical features of the disease and its therapeutic management with the use of therapeutic plasma exchange and immunomodulation are similar to adults. Therefore, there is a high unmet medical need for the use of Caplacizumab in the pediatric population with adequate doses. A full pediatric program for such a rare disease is challenging. While pediatric cases are described in the literature, our Phase 2 and Phase 3 trials were open to pediatric recruitment, but no pediatric patient could be enrolled. In this case, it has been deemed necessary to provide dosing recommendations based on a PK/PD model developed in adults. The adult PK/PD model integrated different interplaying components and accounted for the interaction of the drug with the target, the disease progression, and the effect of the standard of care on the pharmacokinetics and the pharmacodynamics. It described the turnover and homeostasis of the von Willebrand factor, the absorption and disposition mechanism of the drug, and the disposition of the drug-target complexes. The pediatric simulations were done following the process illustrated in this slide. First, virtual pediatric populations of different ages were created. Then a standard study design was defined, and it consisted on the use of an initial intravenous dose of 10 mg Caplacizumab, followed by a 1-hour plasma exchange, given daily for 7 days. At the end of each plasma exchange, a subcutaneous dose of 10 mg Caplacizumab was given. The post-plasma exchange period included a daily subcutaneous dose of 10 mg Caplacizumab for 14 days. The model was based on several assumptions, including gender distributions of target levels, distribution of body weights related to the age groups, and an important assumption was done on the absence of any growth effect on the pharmacokinetics and pharmacodynamics related to the use of caplacizumab. The simulations were done for a fixed dose, as in adults, or following a body weight tiered dosing approach. This slide shows the results of the pediatric simulations for a fixed dose of 10 mg once daily subcutaneously, as in adults. On the left panel, we can see the predicted exposure for the different age groups. We can notice that, compared to adults, the exposure would be higher for ages lower than 10 years. On the right plot are reported the individual exposures by body weight, and the three colors correspond to the different populations. In green we have the adult population, in dark blue children with a body weight higher than 40 kilos, and in pale blue children with a body weight lower than 40 kilos. Based on that, it was decided to consider a body weight tier dose adjustment, taking 40 kilos as the threshold body weight for adjusting the dose. This slide shows the results for the pediatric simulations using the body weight tier dosing approach. This consists in the use of 10 mg caplacizumab given once daily subcutaneously to children with a body weight higher than 40 kilos, and using half of the dose of caplacizumab, 5 mg once daily subcutaneously, for children with a body weight lower than 40 kilos. These dosings would ensure the attainment of an exposure similar to that in adults in all the age groups, as illustrated on the left-hand side, and on the right-hand side, where the predicted individual exposures are reported by body weight for adults and pediatrics. In conclusion, modeling and simulations was used to provide guidance on dosing regimens to be used in pediatric ATTP and was the basis for the approval in Europe of a type 2 variation on the therapeutic indication, including adolescents with a body weight higher than 40 kilos without any clinical trial. Furthermore, the dosing guidance has been used in post-marketing pediatric cases, confirming the adequacy of the proposed dose adjustments.